of NHSRC and DPSRU, welcome you all for the 18th STG lecture on skin and soft tissue infections. We have already completed, the pre-test link is in the chat box. You can attempt through the link. Now I request Dr. J.N. Srivastava sir, Advisor QPS, NHSRC, to welcome you all and set the objective of the lecture. Over to you, sir.
Thank you, Dr. Siddhi. And great. Okay. No, yes. So, very good afternoon to all of you. And at the outset, I welcome all the participants from the state, from the facilities, because without your active participation, this series, now 1.5 years have gone, would have not been possible. And this kind of endeavor requires support from the top management, which our ED, Major General Professor Atul Kotwal, have been in the forefront since beginning in the endeavor to improve the clinical knowledge and the skill of all the practitioners who are there in the field. And with this purpose in mind, NHSRC and Delhi Society for Promotion of Rational Use of Drugs entered into a MOU for promotion of the rational use and also adherence to the standard treatment guidelines and for skill and knowledge upgradation. Few of you may recall that under Ayushman Arogya Mandir, which are operational in the country, they are the primary vehicle for the community to avail the primary health care. And within the package of the primary health care, delivery of, the treatment, first initial treatment of the common conditions, which largely constitute the elements which the community suffers, is one of the critical package. And within this skin infections, soft tissue infections are the common occurrence in the field, in the communities, all of us must have encountered. I must acknowledge the support and the leadership in the clinical excellence provided by Professor Sangeeta Sharma, who has been single-handedly working with us in taking this agenda forward. And of course, the support of and guidance of Major General Professor Atul Kotwal is deeply acknowledged. And today also, here having the many priorities, he has taken time out to address us all. Please post your queries. We have got an eminent expert today, Professor Archana Singhal, and who will be introduced later on. And post your queries and don't hesitate in addressing any common problems or any rare problem also you may have encountered. And that's where, then only the objectives of this webinar series would be achieved. So I would request now our ED, Professor Atul Kotwal sir, to address all of us.
Thank you, sir. Good afternoon, everyone. And it gives me great pleasure to be here amongst you all once again as continuing part of our lecture series. And I must compliment Dr. Sangeeta Sharma and Dr. J.N. Srivastava sir and entire QPS team for continuing with these series, and also must compliment all the participants who join in on alternate Saturdays with us and take part in these webinars. And today's topic, as already mentioned by Dr. J.N. Srivastava sir, a very important topic and sometimes very neglected one also, the skin and soft tissue infections. These have increased over a period of time, and they contribute significant burden on the healthcare system also, and increase also in terms that the more cases being diagnosed as such, and as skin and soft tissue infections. Because earlier, a lot of these probably were missed also, and systemic treatment was many times given. And the challenge of these skin and soft tissue infections is, to efficiently differentiate the cases which require immediate attention, and those either medically or surgically, and from those which are less severe. And sometimes the progression sometimes, is very, very, uh, it can't be made out that what is the speed of progress to become severe infection. So that also, many times leads to complicated cases subsequently. And there's another aspect in this, which is a psychological aspect, that many times people with some kind of skin afflictions and all do not want to, tell people that they have this kind of disease, unless it is visible somewhere outside. And till it increases to a certain extent, and then the treatment becomes prolonged. And the inflammatory response, which is, if it is known immediately, then of course people take treatment, and diagnosis becomes easier. But many times it's a slow skin condition which takes a long time to develop. And of course, there are hardly any emergencies in skin, but then the ones which are like bullous pemphigus vulgaris and all, those which are life threatening as such. And the topic as such will again add to the topics which I've been discussing, and I'm sure the specialists, doctors, CHOs, staff nurses, and professionals from different disciplines who have joined us today will greatly benefit from this. And today's expert, as mentioned earlier, is Dr. Archana Singhal, who's Director, Professor, and Head of Department of Dermatology, UCMS, New Delhi, will be talking to us on this topic: skin and soft tissue infections, from diagnosis to treatment. And Dr. Sangeeta Sharma would also be discussing with us about optimizing antibiotic use in SSTI, skin and soft tissue infections. So I once again congratulate all the organizers, and also thank and all the participants to have joined in today, and wish you all the very best for an interactive session. And as the advisor QPS already mentioned, that please feel free to ask questions in the chat board, so that all queries are answered in this session only. Thank you very much for giving me this opportunity to be with you all, and wish you all the very best. Thank you.
Thank you, sir. Now I'd request Professor Sangeeta Sharma to introduce the eminent speaker and start the series.
I guess Sangeeta ma'am mute.
Yeah, I was on mute. I have a great pleasure of introducing Dr. Archana Singhal. She's a renowned dermatologist, not only in India, but she is a world-renowned dermatology, and she's very, very actively working in the field of teaching others how to go about this. Currently she is director, professor, and head of the department of dermatology at UCMS, with more than 28 years of experience, and a lot of publications to her credit, 260, and she has edited 4 books, 350 presentations nationally and internationally, and she is currently the editor of British Journal of Pharmacology. That's a very, very prestigious job that she has taken voluntarily, and which takes away a lot of her work also. And she is also founder president of Nail Society of India, former president of IADVL Delhi State Branch, and she's been awarded Teacher Par Excellence Award by IADVL in 2018, and earlier Sardari Raj Memorial Award for Academic Excellence in 2010, and she's been awarded with Cystopic Oration in 2013, and DSB Oration in 2023. Her areas of interest are tropical dermatology, nail disorders, and pediatric dermatology. And also, if you have seen our book, Standard Treatment Guidelines, she is the lead contributor right from the beginning in this book. She has actively contributed the pictures that you see in that book, which are very much informative and very good selection of photographs. So we've been working together for last more than, I think, 20 years now. Uh, uh, so with great pleasure, I invite you over to you, Dr. Archana, for your session today.
Archana ma'am, you're on mute.
Okay. Thank you. Good afternoon, everyone. Thank you, Dr. Sangeeta, for inviting me to present this, and thank you for the kind introduction. There have been some glitches about, so I'll be saying next for the slide. And I'm extremely happy to be associated with Dr. Sangeeta, who has taken up such a challenging task of the promotion of the rational drug use. And having skin and soft tissue infections as a session itself is a very daring effort, because it doesn't, people think that it's a very, very simple thing, but most of the time, if we see the prescription of even the qualified doctors or medical officers, the diagnosis is not given correctly because everybody thinks that, okay, bacterial infections, it's just all right, give antibiotic and all, but there is much more to than just saying skin and soft tissue infections. Since we are catering to a large different category of people, my presentation is extremely basic, and but it will give you a fairly good idea, what you can treat as a medical officer or as a nursing staff in some dispensary, and most importantly is that when you should refer to a dermatologist. As our the chief guest, he told us that there are very few fatal conditions in dermatology, but when they are, they need to be referred to the specialist in time. Next, please. Next slide. Can we move the slide? So the agenda of my talk is to know the normal flora of the skin and its importance, to get acquainted with the clinical presentation of various common bacterial, fungal, viral, mycobacterial infections and infestations, to be able to recognize and suspect these infections, to perform common office diagnostic procedure, and to prescribe common antimicrobial, which will include the antibiotics, antiviral drugs, antifungal drugs, and most importantly, to know when to refer to a dermatologist. Next, please. So this is our body has a normal microflora in all the areas. So there are certain areas, like we call them seborrheic areas, which include the head and neck, upper back, and the chest, which are very, very rich in sebaceous glands. So they have they have propionibacterium, corynebacterium, and other actinobacteria. And there are other areas, depending on, which have staphylococci and other organisms as a normal flora. Now, these normal flora are very, very important, and they are microbial resident flora, but they help in preventing the infections from the pathogenic microflora. Okay, so these are very important, and this is important when you actually clean your body. Next slide, please. So, like, we have aerobes, which are gram-positive, cocci, like Staph epidermidis, micrococci, bacilli, corynebacterium, like Brevibacterium epidermidis. Certain gram-negative bacteria are also part of the normal flora, like Acinetobacter. And anaerobes are there, like Propionibacterium acne, granulosum, and they are present in the hair follicle. Next. So how do they help? So they help in cutaneous self-defense. That means they help prevent the skin infection by the other pathogenic bacteria. Okay, so how does that happen? They are on the surface of the skin. So by desquamation, the pathogenic bacteria get dislodged. In desiccation means when there is a dry atmosphere, or acid mantle is also protective. The acid mantle, and that's why most of the soaps, if you take with high pH or alkaline pH, which are cheap soaps, they robe the skin of the acid mantle. And that's why in the alkaline medium, there are more and more invasion by the pathogenic bacteria. And then there is a mechanism which is known as bacterial interference. That means if the resident flora is strong and viable and present, it will not let the pathogenic bacteria reside and localize and be there. Once it happens, then they cause the disease or the different infections. Secondly, sebum, I showed you that the face and the upper back and the chest, they are the area which are known as seborrheic areas. So they produce sebum has oleic acid, which also inhibits bacterial growth. In a nutshell, in last 3 to 4 slides, there is just one message that we have a normal bacterial flora on our body, which helps us in not getting the infection by the pathogenic bacteria, right? Next slide. So we know that we tell everyone, every skin specialist will say that, okay, you should bath and clean with soap and water. It is very, very essential. There are many people who say that we do not use soap or, but continuous and prolonged use of antibacterial soap or agents, like many people use Savlon soap or Dettol soap, or they add neem extract. They kill the resident flora if used for a very prolonged time, and then they predispose to the pathogenic bacteria, right? And most of these agents are alkaline, thereby depriving the skin of the fatty acid and lipids, and making the skin dry, and thus lead to breach in the barrier function. The 80% of our barrier function of the skin, that means it acts as a first line of defense, that lies in the uppermost layer of the skin. And when we keep applying these soaps, this antibacterial soap for a very long time, there is a breach in this barrier function, and that again predisposes to the pathogenic bacteria. In addition, prolonged use of concentrated betadine or Savlon or Dettol or neem, boiled neem people use, they can cause irritant contact dermatitis. Now, dermatitis, as you can sense, itis, that it's inflammation of the skin. So again, there is breach in the continuity of the skin, breach in the barrier function, and thereby making the skin more predisposed to all kind of infections. So, and it is also seen that these fancy soaps, which are called antibacterial soap, which contains triclosan, they're very expensive. Like one of the bar will cost you around 250 to 500 rupees. But it has been shown in numerous studies that it has no advantage over an ordinary soap, right? So it is essential to use soap for cleaning, but it is not good to prolonged use of antibacterial soaps or antibiotics on the body. Next, please. So all these kind of infections, they have some predisposing factors. They're more in certain population, like in areas where there is overcrowding and intrafamilial contacts with bacterial infection or fungal infection. Poor immunity, which can be because of the poverty and malnutrition, that's very prevalent in India, certain sections. Poor sanitary practices, so you don't wash your hands properly, and there are number of bacteria that gets lodged on hand, and then they get on other areas of the body. Lack of hygiene, not taking bath for say 2 to 3 days or up to 5 to 7 days is a very, very common practice in most of the patients from the economically compromised strata of the society we cater to. And diabetes and other metabolic disorders, they also predispose, especially the uncontrolled diabetics. And then when there is irrational use of antibiotics, it enhances the antibiotic resistance, and thus the commonly used antibiotics, which are say amoxicillin or cloxacillin, they are no more, there is a community resistance and the hospital acquired resistance also. Next. So I have classified my presentation into bacterial infections, fungal infections. Can you show the previous slide, please? Viral infections, mycobacterial infections, and these are the common infections which as a physicians which come across. Next. So I'll be starting with the bacterial infections. Next. So the bacterial infection of the skin, the umbrella term used is pyoderma, but it doesn't convey anything. It doesn't convey what we are talking about. Pyoderma is just a umbrella term for bacterial infection, and it is mainly caused by two type of gram positive organism, staphylococci, which can invade the intact skin, and group A beta hemolytic streptococci, which usually traumatized skin. Then there are other bacteria like Pseudomonas and Corynebacteria, right? And gram-negative bacteria are very difficult to treat, Next. So how can we classify pyoderma? We can classify pyoderma as primary and secondary, and as superficial and deep. So primary means there has been no previous breach in the continuity of the skin, and it can be superficial. Now it is very important to know what is superficial and deep, because that will decide our treatment strategy, right? In superficial, you may not require to give oral antibiotic or systemic antibiotic or injectables, and they can be treated with the topical antibiotics, while all deep bacterial infections, they have to be treated by oral antibiotics or injectable antibiotics. So superficial infection will include follicular, like superficial folliculitis, means hair follicle inflammation of the infundibulum of the hair follicle, follicular impetigo and non-follicular impetigo. Deep will include psychosis Barbie, fruncle, carbuncle. I'll show you the pictures. And non-follicular will show ecthyma, cellulitis, erysipelas, and paronychia, which is the inflammation of the nail fold, and necrotizing fasciitis, which is a medical and surgical emergency. And then there can be secondary pyoderma, means that there is some already existent skin condition, which can be eczema or atopic dermatitis or ulcer, and it gets secondarily infected by the bacteria. Next. So coming to the primary infection first, the direct infection by Staphylococcus aureus can lead to impetigo, ecthyma, superficial folliculitis, fruncle, carbuncle, and cellulitis, while there can be some infections which are toxin mediated. The Staphylococcus aureus release some toxins which can cause staphylococcal scalded skin syndrome, which will usually come to the dermatology, and toxic skin syndrome, as the name suggests, has got mainly systemic features, and patient primarily may not present in dermatology, but he will present in emergency. Next. Streptococci causes impetigo, fruncle, cellulitis, ecthyma, and it can also lead to toxin-mediated rash, which is known as scarlet fever. Next, please. So superficial folliculitis, as the name suggests, is the inflammation of the terminal part or the infundibulum or the opening of the hair follicle. It is caused by the Staphylococci aureus, but it can also be caused, it can be non-infective also. Say contact with, when you massage with the oil, it can, hum bolte hain baal tod funsi ho gayi hai. But if it is very superficial, it can be, traumatic also. Clinically, it appears as small pinhead follicular pustule with surrounding erythema, and they heal without scarring. So superficial infections, all of them will heal without scarring because they are present only in the epidermis. Any infection that is extending up to the dermis or subcutaneous tissue are deep infections, and they will always heal with scarring. And in superficial infections, they can be self-limiting, just cleaning and topical application of antibiotics like fusidic acid, mupirocin. Twice daily application can cure the conditions, and oral antibiotics are not required. Next. So this is like superficial folliculitis. This is epidermis and this is dermis. So as you can see, the inflammation is confined to the epidermis at the entry point of the hair follicle. This is the hair follicle, right? So this is the picture. So there is a small superficial lake of pus, which is perifollicular, and you can see that there is no marked erythema or induration. The induration happens, or the pain and tenderness happens when there is involvement of the dermis. Next. Impetigo is a very common condition in pediatric age group, and it can be caused by both Staphylococcus aureus and group A beta hemolytic streptococci. It usually affects the face in the perioral or the perinasal area. So initially there are very small thin-walled pustules. Pus-filled lesions are there which break, and there is a characteristic honey-colored crusting. As you can see, the yellow-colored crusting is there, and because it is superficial, it is only involving the epidermis, it heals without scarring. But if the etiological agent is group A beta hemolytic streptococci, then one has to be very, very careful, because even after the successful treatment or resolution of the lesion, patient can have post-streptococcal glomerulonephritis as a complication. Next. So this is bullous impetigo. It is caused by Staphylococcus aureus, and it is caused by epidermolytic toxin. So the Staph aureus, the organism releases a toxin which is epidermolytic, means it lyses the epidermis, and this lead to the formation of blister. Like this, there is an intact blister, as you can see, and it again heals like there is a small crust formation, and it heals without scarring. Next. So the diagnosis, how do you diagnose these impetigo? Impetigo contagiosum or impetigo bullous impetigo. They are mainly clinical in the perioral, perinasal area in children, and honey-colored crusting. But sometimes you can take skin swab for gram stain if patient has taken antibiotic and not responding. How do you treat them? Maintain hygiene, cleaning with soap and water, and because what happens that whenever there is skin infection, people don't stop using soap and water, but you have to use soap and water. Remove all the crust gently so that the area is exposed for topical application. Otherwise, if you apply topical antibiotic over the crust, it's not going to penetrate where the infection is actually there. If it is widespread or recurrent or associated with fever or regional lymphadenopathy, that means it's become systemic, and then you need amoxiclav as the first drug of choice, 30 to 35 milligram per kg body weight for 7 to 10 days. And if it is still recurrent and it is resistant, then you refer to a dermatologist, because pus for culture sensitivity is to be done. And if it is MRSA or methicillin resistant Staph aureus, then it need to be managed by a specialist. Next. Ecthyma is another infection by staph and strepto that's characterized by the formation of adherent crust. And this is a leathery crust, as you can say, leather-like crust. And it is more commonly seen in diabetics, immune compromised, associated with malnutrition and poor hygiene. Usually it occurs on extremities. And there is a big, you can see this, the lesion is this much, but there is a surrounding erythema. Somebody is saying that the slide is not visible. So if you remove this crust, which we do after soaking it with the saline soaked swab, putting it over, and then you can see this. And since it's a indurated lesion, you can see how big the lesion is. and this is otherwise the opening of the lesion. So it is indurated, it is involving the dermis. Therefore, it will heal with scarring and systemic antibiotic is required. Next. Now, deep folliculitis, as I told you that superficial folliculitis when only the intraepidermal part is involved. Deep folliculitis, as you can see, the whole length of hair follicle is involved, and this is in the dermis, at the junction of dermis and subcutaneous tissue. So it can cause, it is known as psychosis Barbie, as the name suggests, when it is happening in the beard area, frontal or carbuncle. I tell you, if there is a single follicle which is involved, it is not with the surrounding dermis, it is known as frontal. But if there are multiple follicles are involved with the intervening dermis also, then it is called carbuncle. Next. So this is psychosis Barbie. This is the beard region, neck region of a patient, and you can see multiple deep folliculitis lesion. Okay. So if there are too many and closely placed, then it is known, it gives you a, a red plaque, which is like, gives fig-like appearance. Next. Next. Okay, so this is frontal. Now, in this stage, it is very rarely that patient will come to you. This happens in first 48 hours and patient tend to rupture the lesion. So this is a single follicle, right, which is purulent, and this is a surrounding area of the dermis which has got infected. It is caused by Staphylococcus aureus always, and this is the same patient after it has ruptured. So generally when patient come, they come in this stage, right? So it is very painful. Throbbing pain and tenderness is there because there is inflammation of a single follicle first. There is a pustule small which become larger and then it rupture to form a deep erosion. And you always have to give systemic antibiotic, and patient may have constitutional symptom in the form of fever, lymphadenopathy and myalgia and arthritis. Next, please. Now, as I said, in carbuncle, multiple contiguous hair follicle. So we have superficial folliculitis when there is superficial part of the hair follicle is involved. We have deep folliculitis when only the hair follicle is involved, but whole length of hair follicle. Frontal when the hair follicle is involved deep, but there is surrounding involvement of the dermis also. That is frontal. Now, carbuncle is when there are multiple closely adjacent hair follicle involved with the involvement of the intervening dermis. So this becomes a huge, big indurated mass. And you can see these small pustules, which are all perifollicular. Okay. So this gives like a sieve-like appearance, as if chalni mein se kuch chan rahe hain aap. And it is a short feature of diabetes or immunocompromised patient, and usually occur on buttocks and nape of the neck, where there is a lot of hairy areas. So pus discharge from multiple openings, as you can see here, gives sieve-like appearance. Next. So this is as a whole, how this happens. So folliculitis, it can be superficial or deep. Frontal when there is surrounding epidermis but single hair follicle, and carbuncle, this is a pictorial depiction when there are multiple hair follicle and in between it the dermis is also involved. Next. Coming to other bacterial infections which are again common are cellulitis and erysipelas. Erysipelas is infection of the dermis and upper subcutaneous tissue, while cellulitis is acute, subacute, chronic inflammation of the subacute. Now, if the inflammation is superficial, dermis hai yahan par, so it will be well defined. Cellulitis, on the other hand, has dermis and deep subcutaneous tissue also. So it is deeper infection. So it will not be on the surface. It will not be very well defined. And it is, the erysipelas are exclusively caused by group A streptococci, while cellulitis can be caused by streptococci as well as staph aureus. And again, the predisposing factors are the same. Next. So clinically, I'll show you the next picture. Next, please. So this is cellulitis. Most of the people develop it on the, on the buttocks, or where they have been scratching. So previous there is injury, and then there is extremely painful swelling of the area with erythema, and ill-defined erythema at places you don't know where it is ending. And it is associated with fever, lymph node, very painful. All signs of inflammation are there. Erysipelas, on the other hand, you see it's so well defined. You can see it again, hot to touch because it is inflamed, but it is very well defined. It is very easy to demarcate the line, where the lesion is. While in cellulitis, it doesn't happen because it is involving the deeper dermis. Next. Coming to a very medical and surgical emergency, it is necrotizing fasciitis, which is still deeper. Means it will involve the dermis, subcutaneous tissue, muscle, fascia, and subcutaneous fat. Now, subcutaneous fat, we know that fat is not vascular, and that's why there is no defense. So there is rapid progression overnight, or in few hours, there is progression of the infection. And muscle tissue is frequently spared because there is blood supply, and initially sometime there may be just deeper infection, and the on the skin you may not see anything, but in few hours it will be necrotic, and you can see the deeper in tissues also. Next slide please. So see, this is the, like previous night, this patient may not have anything, just erythema and pain and tenderness, but on the very next day, he will develop this ulceration, and there is, necrotic area, which is very fast spreading. Sometimes you can see tendons also. If there is area like on sole of the, on the dorsum of the foot, not much subcutaneous fat is there. So there is epidermis, dermis, and subcutaneous and tissue, and right there are muscles and tendons. So you can see sometime, and this has to be debrided as soon as possible. It's a surgical emergency, and IV antibiotics have to be given. If the diagnosis is delayed, then gangrene may settle in, and sometimes there is auto amputation of the lesions. And it is the compartment syndrome is that, fasciotomy has to be done, otherwise there is rapid spread of the infection once it becomes deep. Next. Then these days we less commonly see, but staphylococcal vitello or the Fallon, you can see there is a pus filled lesion on the finger, and this is always involve the distal end of the finger. You can see the proximal part is uninvolved. It is very painful, red, hot, because there is no space where the pus can accumulate. So there is abscess formation, and we have to differentiate it from herpetic vitello. But in herpetic vitello start when you have, closely set deep vesicles initially. And X-ray has to be done to rule out the underlying bony involvement, and there has to be surgical drainage and systemic antibiotic. Next, please. The other common infection which we'll see during summer, especially rainy season, is periporitis. Periporitis is the inflammation of the acrine or the sweat glands, and this generally happens in children. They have this gonorrhea kind of thing, and we have this people apply a lot of oil, so there is occlusion of the sweat glands. So it's a very important that you have to tell them that they shouldn't apply oil in summers, and because it clogs the acrine glands, and they also should take bath with soap and water. So this usually are in between the follicle. You will not see, you have to differentiate it in folliculitis, but acrine glands occur between the hair follicles. So none of the lesion will show a hair follicle coming out. While in folliculitis, you will always have a lesion which is centered around follicle. Okay, so systemic antibiotic is required because the sweat gland, they are found in deeper dermis, coiled glands, but they come up on the surface of the skin. Next, please. So coming to paronychia, as the name suggests, it's the inflammation of the nail folds, which can be proximal nail fold or the and this can happen following the chronic paronychia or manicuring and pedicure. When the women go, even now the men also go, generally the cuticle is removed, while the cuticle is the one that forms the defensive barrier to the infection. So it is again more common in diabetes, and homemakers who constantly have their hands immersed in water. So it can be classified as acute paronychia or chronic paronychia. Next. So this is like paronychia, acute paronychia. You can see there is a swelling, and this is so painful that patient can land up in emergency in the middle of the night also. And it can be caused by both Staph aureus and group A beta hemolytic streptococci. And what you have to do, if you are at home and you can just take a 20 gauge needle or 23 gauge needle, make multiple puncture to just let the pus come out, and there is immediate, it's like a magic wand. There is an immediate relief of pain because the pus has come out, and it's painful because there is no space for the pus to accumulate. Next, please. So treatment are like systemic antibiotic. If there is without abscess, you can give just antibiotic, but if there is abscess, you have to do incision and drainage, which can be done with the needle prick also. Next. So I told you that these are the infections which we have dealt with by the direct bacterial invasion, but they are certain toxin mediated. If the infection is toxin mediated, then even if there is pus, you will not be able to culture the organism, because it is the toxin. It is not the organism that's causing the infection. It's the toxin released by these organisms or by bacteria, which causes the lysis or the disruption of the skin. So this lead to blister formation. And next, please. So we know staphylococcal scalded skin syndrome. So there can be a focus of infection even in the ear. Okay, and the toxin is released, which will settle down in some area of the body, any area. It can be trunk usually or buttocks, and it will lead to the formation of very superficial blisters, which will break easily and leave the raw area, as if peeling of skin is there. And the diagnosis is by swab and culture of the blister fluid will be sterile, because I told you it's not the bacteria which is present there, it is the toxin, and no organism are seen on gram stain. Next, please. So this is the picture, these are the sheet of skin is you can take off, and the child is sick, fever is there, and the areas are very raw and tender. So it's very difficult to even hold the baby, because even holding him will make him cry more. Next. So what is the treatment? Treatment is IV antibiotic. Managing the skin care is very important in a very, the temperature should not be very low or very high. And because if the skin is not there, there is loss of water from the body. So hydration has to be maintained. And first line treatment are like fluoxetine, clindamycin, and if first line, if MRSA is suspected, then we have to give vancomycin or linezolid. Next, please. The mortality rate is high. I'm not taking up toxic skin shock syndrome. It is just that it is a more severe form of the staphylococcal scalded skin syndrome, and patient will have generalized erythema, systemic symptom, and patient is usually admitted for some other surgical intervention. Next. So there are cardinal signs and symptoms of the septicemia. Okay, and multi-system failure can occur. So patient generally don't land in OPD, they land in emergency. Next. Next. So again, the treatment, if patient comes to you, is IV, and these patients are to be referred. Next. So again, a common infection is erythrasma, which is, as I told you, is caused by the Corynebacteria are also part of the normal flora, but this is not Corynebacterium flora, normal flora. It's different, minutissimum, and again, it is more seen in diabetics, more seen in obese people, which will give asymptomatic red-brown lesions in the flexural area, whether it's the axilla, groin. And on Wood's lamp examination, which is a special lamp we have, it will give coral red fluorescence because it produces certain agents, Corynebacteria, which gives this fluorescence. And it can be treated with oral erythromycin or tetracycline, or topical antibiotic also works. Can we have the picture, please? Next. Yeah. So this is the this is well-defined erythematous lesion. So patient usually are treated like it is tinea cruris. Okay, but there is no scaling, and it is extremely well defined. As you can see, regular margins, macerated lesions, and Corynebacteria, it's very difficult to grow them because they are lipophilic. The tinea cruris, you can do scraping for fungus and see under the microscope, it will show hyphae, but Corynebacteria infection will not show hyphae. And this responds to antibiotic, while tinea will respond to antifungal. Next. Trichomycosis axillaris is again an infection by Corynebacteria tenuis, and it involves the axillary and pubic hair. And you can see, next please. You can see, next slide, there are involvement of the area, and on the hair, axillary hair, you can see yellowish concretions. So if you plug this hair and see under the microscopes, there will be small nodules around the hair, which are composed of the colonies of these bacteria, which are Corynebacterium tenuis. And though they also respond to antibiotic, but I never give them antibiotic. I just tell them to shave off the hair. It's the easiest way to do because it's a superficial infection limited to the hair follicle. So patient will shave off the hair, the infection is gone, and then can apply topical antibiotic for few days. Next. Petite keratolysis is again Micrococcus is a normal flora, but Micrococcus sedentarius, now it is also known as Chytococcus. It's usually seen in the summer months when it's hot and humid weather, and especially in patients who sweat a lot, and it gives very foul smelling. So there are certain people who take off their socks and it smells like mad. So these are the people who are infected with this Micrococcus. I'll show the picture next, please. Just click enter. Yeah. So this is the picture. This is the picture that you have these macerated soles, because this is the area constantly in touch with the shoe or slipper, and this is the area which is usually not in direct touch with the slipper, in sole area. So sometimes the whole of it can be involved, and there are pits, small pits which are confluent and smells very bad. So correction of hyperhidrosis is important. That can be referred to a dermatologist, that we have to treat the increased sweating, and topical antibiotic cream like fusidic acid, imidazole derivative like clotrimazole, and benzol peroxide also work topical. Okay, and you can also give azithromycin. Now coming to secondary pyoderma. Secondary pyoderma, as the name suggests, that it is pyoderma secondary to something. So patient already has some pre-existing disease. Mostly it is eczema, atopic dermatitis, vasculitis, and on the top of it, there is secondary bacterial infections. So this is showing a patient with candidal intertrigo, but then there is a pyoderma-like lesion because there is purulent discharge. And when you make a smear and do gram staining, you can see the staphylococci. Next. Pseudomonas infection are the gram-negative bacteria. Now, the gram-negative bacteria again are associated with greenish discharge and foul smell. Okay, so and they are more dangerous than the gram-positive infection. Necrosis and gangrene happens more frequently in gram-negative infections. Okay, next. So there can be Pseudomonas folliculitis also, usually in swimming pools, and ecthyma gangrenosum when it is there is large necrotic lesion. And the infection can come from everywhere, anywhere, from the middle ear, and patient can go into septicemia. That means the local infection can become blood borne infection. Next. So how do we manage all these patients of infections, bacterial infections, whether they're caused by staph, strepto, pseudomonas, or whatever? So first you identify and assess the predisposing factor. After making the diagnosis, poor hygiene, you counsel the patient about the hygiene, importance of daily bath with soap and water, correct malnutrition. If there is the recurrent trauma, suppose recurrent trauma in the sense patient is walking bare feet, or they are involved in certain work which involves recurrent trauma. Diabetes, it has to be controlled. If there is pre-existing skin condition like atopic dermatitis, you have to take care of that. It is very itchy, so give something that will control the itch. And you have to address and investigate about other immunodeficiency. Now investigations naturally to look for the predisposing factor, and you remember this acronym scabs. Means you make a smear of the pus, stain it with gram stain, you will see gram positive or gram negative cocci or bacilli. Culture, send for culture if it is recurrent, and antibiotic sensitivity. Now this is very, very important. If patient comes with recurrent infection, culture and sensitivity becomes more important than on the first encounter. Next. So treatment include general measures. Very, very important they are. Clean with normal soap and water regularly the affected area, which generally people stop touching, once they get infection. Gentle removal of all crust and exudate. You just soak it for some time. You apply coconut oil and remove. Regular washing of hands after doing this. Improved nutrition and address comorbidities like diabetes. Next, please. So the management principle is that there is topical therapy. Condy's compresses are very good. They are astringent, they are antiseptic, but it is very important that how do you make it? Once you dissolve a small crystal in a liter of water, it should be very light pink. If it is very dark pink or purple, then it will cause caustic burns. Okay, so if you are able to know, if you are able to judge that how much is to be, don't be in a hurry. Just put one crystal, let it dissolve completely. It should be light pink. And those soaks are very good because of the cap. If you put a gauze piece, soak it in the KMNO4, gently squeeze it, and then put it on the infected lesion. By capillary action, all the exudate and the pus will be soaked, will be taken out, and it helps to remove the crust also. Topical antibiotic, soframycin is a big, big, big no. I know everyone in the dispensary has soframycin, but soframycin is a potent sensitizer, means it can cause allergic contact sensitivity. So what are better are fusidic acid and mupirocin, right? And nadifloxacin, especially from the gram-negative organisms. And neomycin and framicidin, which is like soframycin, should not be used. That's why I've marked them in red for a longer time, because they itself can perpetuate the disease by the contact sensitization. Next, please. Then, when do you give systemic therapy? When there is fever and tachycardia, when there is regional lymphadenopathy, when there is systemic infection, when the danger area of the face around the nose and the lips. This is the danger area, because if there is an infection, retrograde spread of infection, it can lead to cavernous sinus thrombosis in the brain. Okay, so that's why it is known as danger area. So whenever the lesion is present in the perioral area, upper lip peel, please do not squeeze the lesion. Rapidly progressing pyoderma and involving a greater body area, so that it is very difficult to apply the topicals. And what are the available systemic agents? They are the penicillins, cephalosporins, macrolides, tetracyclines, and quinolones. And if there is MRSA or methicillin resistant, linezolid and vancomycin. Next, please. And we also have to look for the MRSA carriage. You know, sometime when there is repeated infection, repeated folliculitis or repeated furuncle, then you have to look for nasal carriage of the staphylococcus. So when to refer to a dermatologist? If patient is immunocompromised, suppose a patient of HIV or PLHA, we call them, if they develop infection, severe and widespread lesions with systemic symptoms, high-grade fever, symptom of sepsis. When the sepsis, now the septicemia is sometimes there is just a small focus of entry of bacteria, but it can lead to sepsis. Means the patient is febrile, deranged, the metabolic functions, recurrent and resistant cases, and severe systemic disease such as SSS and toxic shock syndrome. Next. So they are the, indications. Please enter. So this is the chart, how do you go? So if there is mild or localized infection, topical mupirocin and fusidic acid with or without antibiotic. And these are the antibiotic we prefer: amoxiclav, cephalexin, cloxacillin. If patient has moderate fever, there is lymphadenopathy, there are multiple lesions and there is abscess, so you do incision and drainage and always give oral antibiotic. If there is feature of sepsis, then again you can give an IV antibiotics. Okay. And if there is no improvement or patient is immunocompromised, please, then or patient has MRSA, then you have to resort to vancomycin, linezolid or clindamycin, or if it's methicillin sensitive, then you have to resort to third generation cephalosporin. Treatment of non-purulent infection like erysipelas, cellulitis, when you have seen it is just the erythematous, it's non-purulent and necrotizing, but they are deep infection. So there is no scope of or no role of topical antibiotic. You have to give either oral antibiotic or IV antibiotic, or if there is septicemia or in necrotizing fasciitis, you have to do surgical debridement also along with IV antibiotic. And I will add, then necrotizing fasciitis, I always prefer to cover anaerobics also by metronidazole, that I forgot to mention. Anaerobes, I have written anaerobes. So metronidazole has to be added in addition to the gram-negative and gram-positive coverage. Next. So this is a very important this thing where I have given the adult dosing and children dosing, adult and children weighing more than 40 kg and children less than 40 kg. So in children less than 40 kg of age, we will give by the body weight, while in the adults and children weighing more than 40 kg, there is a standard dosage regime. So amoxiclavulanic acid is my first drug of choice to go to, and cloxacillin. And then you can go to, ceftriaxone, IV drugs, linezolid, vancomycin, if it is MRSA, piperacillin, tazobactam, based on the culture sensitivity pattern. Next. So MRSA, I'm saying, no, methicillin resistant. Now, this is very important because it's a special group of staph aureus, which is resistant to a large group of antibiotics, the beta-lactam antibiotics. So the cephalosporin, so amoxi will not help, clox will not help, cephalosporins will not help. And the prevalence is pretty high. It, ranges. So the treatment is linezolid and vancomycin. And if there is a nasal carriage, then you have to advise patient to take either rifampicin, I prefer, for 14 days, or along with 6 weeks course of topical mupirocin in both the nostrils, morning and evening. And one has to ensure that patient has to wash his hands before applying cream and after applying cream. And it should not be crossover, because sometimes there is involvement of one layer, and if you cross it over, then it will be both. And I also advise patient to do perianal application of antibiotic also, because people say nasal carriage, but we have seen in one of our study that perianal nasal carriage is also very important. Next, please. Coming to Pseudomonas infection, now in gram-positive, we were saying that clean with soap and water, Condy's compresses, but for Pseudomonas infection, 1% acetic acid compresses is extremely good and efficacious. So in all our indoor patients who grows, Pseudomonas, we give acetic acid soaked gauze pieces dressing. It is very effective, and you have to give, instead of amoxiclav and penicillin, and you have to give ciprofloxacin or amikacin, but the amikacin is always injectable, so you have to admit patient. Next. I'm done with the bacterial infection. I hope you have understood. Now coming to fungal infection. I've included fungal infection because they're very, very important. Next. So fungal infection are the dermatophytic infection. Dermatophytes are a group of fungi which include trichophyton, microsporum, and epidermophyton, which causes tinea or ringworm infection, as you say, ringworm. But in last 10 years, 2012 onwards, India is facing a epidemic like situation as far as the tinea infection goes, and it becomes extremely difficult to treat because patients are coming with atypical presentation, patients are coming with extensive disease which we had never ever seen. Like earlier, patient used to come during rainy season in the groin or axilla, and in female under the breast, but these days it has become very common. So these are the kind well-defined lesions, and with the raised margins and central clearing that used to be, and that's why it was called as ringworm. But these days we do not see that typical picture. Next. So these are tinea faciae. When the lesion occur on face, you can see the raised margin here and central clearing. This is because patient, to become fair, they are applying many creams which contain steroid, and steroid will cause decrease in the local immunity, and dermatophytes are always there in the environment. They are ubiquitous, means they are always present everywhere. So once there is a localized decrease in the immunity, they will infect and cause tinea faciae. People use Betnovet N, which is like a cold cream for face in many communities. Then tinea pedis when it involves the sole, and tinea manum when it involves the hands. Next. So how do you diagnose such infection? There is an active edge of the lesion. You can scrape it and see under the microscope. In tinea capitis, when hair is involved, you can pluck the hair. And when nail is involved, you can collect subungual debris and put it in the KOH solution and see under the microscope. One can also go for fungal culture. For that, you have to refer. Next. So in the microscope, you see these branching septate hyphae, low magnification. This is okay. Next. So treatment for the localized disease, you give creams for at least 2 to 4 weeks. Clotrimazole 1% or miconazole 2% or terbinafine 1%. They are all available to be applied twice daily for 2 weeks. The rule of 2 is there. For 2 weeks, 2 centimeter beyond the margin, and after the lesion has resolved completely, 2 more weeks. So it's a rule of 2. So twice daily application for on the area 2 centimeter beyond the lesion, and 2 weeks after the lesion has resolved completely. If there are lesions are extensive, as you saw in the picture, then you can give tablet terbinafine 250 milligram daily for 2 to 4 weeks, or capsule itraconazole. But for itraconazole, you should send patient to a dermatologist because it has got cardiac complications and it has many drug interactions. Fluconazole can also be given 3 to 6 milligram per kg body weight per week for 4 to 6 weeks. And greaseprevir, but greaseprevir only if it is micronized formulation. If it is macronized formulation, the dose is very high and it causes hepatotoxicity and agranulocytosis. Next. So this is tinea capitis. This is newborn child, home born and acquired from some cow dung application was done for the child. Okay, next. So these are different presentation of tinea capitis, means tinea infection of the scalp. This is called gray patch when there are multiple scaly patches on the scalp. These are black dot variant which lead to breakage of the hair as they come out from the scalp. Next. Then there are inflammatory variant, chirion, where there are abscess formation, and inflammatory pustular. You can see pustules. So all these patients require, hair and nail always require systemic treatment with either terbinafine or greaseprevir. Greaseprevir is a good drug for tinea capitis. Okay, but it has to be given for 8 to 12 weeks. Patient has to be told that they don't have to share the soap or towel or comb, because there is a spread by the fomite. Fomite are by the articles you use, whether it is towel, sharing of clothes, sharing of soap, sharing of the washing clothes in the same lot. So they should be washed separately. Next, in hot water. Next. And this is the hair on microscopic examination. Treatment is no oil application because it makes the hair more messy and more predisposed. Shampooing with 2% ketoconazole is not that it will cure, but it will prevent the dispersal of spores to other people. Greaseprevir can be given, as I told you, 10 to 20 milligram per kg per day for 8 to 12 weeks. So the treatment becomes very long. For terbinafine, it is like the dose is based on the body weight. So more than 40 kg, 250 milligram, between 20 to 40 kg, आधी tablet या 125 milligram, less than 20, 1/4 tablet. Okay, next. Onychomycosis is the infection of the dermatophytic infection of the nail, as you can see. Next. Yeah, so you can see this whole nail has become dystrophic and there will be multiple thick nail with subungual debris. So if you want to do KOH, you have to scrape from here. Okay, next. So how do you treat them? I think if there is a onychomycosis, you refer the patient, don't treat, because it's a systemic therapy always, and therapy will depend on whether it is a matrix involvement or not. So very difficult to know by the non-dermatologist, if there is one involved, nail involved, and only the distal part is involved, then topical nail lacquer may work. Otherwise, systemic therapy is warranted. Pulse dosing we do, means we give for high dose for 1 week, don't give for 3 weeks. But I think these are the patients who should be referred to a dermatologist. Next. Challenging in treating dermatophytosis. As I told you, India is facing unprecedented epidemic-like situation of superficial fungal infection. There are atypical presentation. Infant and children never used to be involved. Now it has become another scabies. If one person is involved, rest of the family is also involved. Unusually extensive disease, atypical morphology, which there is no ring. It's all plaque. Poor response to conventional treatment, or they require very long treatment, and the disease is recurrent, recalcitrant, and relapse very fast. Next. And this is because of the topical steroid abuse. We have Fordum, Tetradum, Pentadum, Octadum, a potent topical steroid Next, I can't see the slide. Hello? Okay. How can this be? I'll go sit near the Wi-Fi, this thing. Am I audible now? Am I audible?
Yes, ma'am. Yes, ma'am.
Okay, so these are the most irrational fixed drug combination of fordum with potent topical steroid, and this is causing the epidemic of superficial fungal infections, not only in India, but all over abroad also. And India is the only country in the world who is making this fordum, tetradum, pentadum, all rubbish, quadridum. So it is not required. If it is fungal infection, give antifungal. If it is steroid responsive dermatitis, give only steroid. Why you want to club it? What is the use of neomycin? What is the use of pentadum also, like antiprotozoal, metronidazole? There is no use. These are causing a lot of harm. Next. And you can see the small children, which we never used to see, having lot of extensive infection. You can see on the face, because the mother is applying, all these medication, and they get from the family members. Next. See, so much extensive infection we had never seen in life before, but now we are seeing commonly. Next. So please do not prescribe topical steroid for any skin infection. I say infection, whether it is bacterial, viral, or fungal. Say no to fixed drug combination of antifungal, antibiotic, and potent steroid. This is one important message from my presentation. Next. Candidal intertrigo. Now we have done, this is maceration, like is very common, and you see satellite lesions. So this is clinically very diagnostic of candida. Okay, and candida will respond to only fluconazole. Next. So keep the area dry. Oral candidiasis, you can see, because candida is a common commensal of the oral cavity and vagina, and if prolonged antibiotic use, prolonged use of steroid, and immune suppression can lead to oral candidiasis or candidal vaginitis, and you see budding yeast cells or pseudo hyphae on KOH examination. Next. So the treatment is only, you remember fluconazole, 150 milligram once or twice a week for 4 to 6 weeks, and topical and clotrimazole paint. And extensive candidiasis can result from immune suppression. So if there is esophageal candidiasis along with oral candidiasis, one should look for HIV/AIDS. Next. Coming to infestation. Next. So scabies, form 30 to 50% of our daily OPD, which should be not be there. They should be treated at the periphery. Why should patient walk in so much to come to a tertiary care center? So scabies is characterized by, now this is secondary pyoderma. Scabies were the primary pathology and got secondarily infected. So interdigital clefts, lower abdomen, genitalia in males, and breast and axilla in females, lower abdomen. So these are discrete excoriated papular lesion with nocturnal. Three important points are discrete papule, intergenital webs, genitalia and lower abdomen. Nocturnal pruritus means that itching becomes worse at night, and there is a family history. They are characteristic of the diagnosis of scabies. Next. So if you scrape these papules and on the genitalia, you see this mite. Next. So how do you treat? There is that you can give 5% permethrin cream, single overnight application below neck all over the body. This is for adult. So say that only face is to be spared and rest 30-gram tube to be applied on all body parts, not leaving even an inch in between the fingers, on the sole, on the scalp. It is very important. Just leave the face, or you give ivermectin and single application. Patient applies at 10 o'clock, morning 6 o'clock he can take bath and wash all the linens he has used, even the bed cover, bed clothes, towels and clothes. Or you can give tablet ivermectin at 12 milligram for adults, and if you want to calculate dose for the children, then 200 microgram per kg. Single start dose can be repeated after 2 weeks. Antihistamines are to be given for long time, 15 days, because it's not just the mite, but because of the allergic hypersensitivity that patient itch. Treat all household members, whether they are involved or not involved, affected, not affected, on the same day. Wash all linen separately and iron all clothes. Iron, I am saying, for dermatophyte also, ironing very important because it requires 60 degree to kill the fungus. Similarly, it requires, because this mite can stay away from the body for 2 to 3 days before it dies. So you have to iron out to, kill them. Antibiotic if secondary infection is present, and nodular lesions if they are present, usually on the scrotum, because the skin is very loose, then only topical steroid, but once after you have given permethrin or oral ivermectin. Next. So pediculosis is again very, very important. Patient comes with secondary pyoderma of the scalp. So you have to see that the primary disease may be pediculosis. Next. And if it is, see, this lady otherwise looked very nice, but she's loaded with pediculosis. The kid was also loaded with pediculosis. Next. And if it is so extensive, sometime you can see pediculosis on the eyelid also. So patient came to, that I have itching all over my eyes. So what you have to do, just एक निकालो, see under the microscope and you will see. And when patient is itching over the body, you see the seam of the clothes. जो सिलाई होती है उसमें ये चिपके हुए होते हैं, right? Next. Or in the pubic hair also they can be present. So that's how they look like. So on the scalp, and sometime you will see only the empty shell. Okay. Next. But they're closely adherent. So you can take out a pediculosis or this empty shell only along the length of the whole hair. And you will never be able to pick them up in between like you do the scales. So the treatment is that 1% permethrin cream rinse. They're differently available than the one used for scabies, which is 5% cream. It is to be applied over the scalp like you do mehendi application. I ask patient to wear either a shower cap or tie it with chunni, and wash it off after 45 minutes and repeat after 10 days, because they're all not the developed mites. The ova and they will take long time to become mite. So usually it's 7 to 8 days, and that's why we ask them to repeat after 10 days. 2 applications. And if there is itching, antihistamine or levocetirizine can be given. If there is secondary bacterial infection, then appropriate antibiotic. In severe infection, it is better to shave off the scalp hair. Next. So ivermectin, just a minute, previous slide please. So if a preventive measure, that all the family members need to be evaluated, and sometimes the mother has to be asked, that they should ask the school going children whether they have friends who have, because they close contact. So kids, they stay very close to each other. And mass drug administration is given only when the prevalence rate is more than 10% in that particular area. So I have asked certain schools, I have written letters, that they should mass administer ivermectin when I see that a lot of children in the class have pediculosis. Next. Coming to viral infections, just 2-3. Next. So herpes labialis or herpes, this can present as in different forms. Next. So these are herpes gingivostomatitis. This is herpetic vitello. Next. But more common is this. This picture is very common. You see, patient कहते हैं कि हमने किसी का जूठा खा लिया, but this is usually after going in cold or after fever. That you get this closely set vesicular lesion which take around 7 to 10 days to disappear. Next. So if you make Zinc smear, they are multinucleate giant cells. Next. So if this is first episode, it will be very painful. Patient will be distressed. Then you can give acyclovir tablet, 400 milligram 3 times a day for 7 to 10 days. If it is recurrent, then only for 5 days. And suppressive therapy is required if there are more than 6 episodes a year, 400 milligram BD for 6 months. Okay. If there is neonatal herpes, then you refer, because patient has to be given IV treatment because there are many lung and CNS complications. Next. Another important thing is herpes zoster and chickenpox. We know that chickenpox have polymorphic lesion on the trunk, while herpes zoster have dermatomal distribution. Next, please. So this is chickenpox. You see, some are papule, some are pustule, some are vesicle, fluid filled, some are crusted. Okay, because there are different crops of lesion. Patient has fever, and herpes zoster is extremely painful. It is unilateral. This is midline of the back and it is on one side, one dermatome. Next. So if it occurs on the ophthalmic nerve of the trigeminal ophthalmic maxillary mandibular, and if there is eye involvement, this is called nose sign, Hutchinson sign. Then when there is a tip of the nose is involved, that means they have a nasociliary branch which will supply to the cornea. There can be corneal opacity. So it is again an emergency. You should refer the patient. Next. So what do you give? Rest for both. Isolation, antihistamine can be given. Acyclovir has to be given in older children, 12 year or more, if they report within 72 hours. Okay. Next. For herpes zoster, the dose is very high, painful. It's a painful condition, and gabapentin and pregabalin has to be given for post-herpetic neuralgia. So I will request you to refer these patients then to treat on your own. Next. Then molluscum contagiosum is very common. It is pox-like condition. In West, people don't treat them because it involutes. But in India, where we are too many of us, children play very closely and there is overcrowding, and it spreads by direct skin to skin contact. So the treatment is essential, and you can either take out each and every body or you can apply 10% KOH, which can be applied at home. Next. Or topical tretinoin can also be applied. This is an umbilicated lesion. It's a very shiny papule with central white body. Next. Coming to hand, foot and mouth disease, it is usually, I have included because it is usually confused with chickenpox, and it is caused by different virus, Coxsackie virus and enterovirus, and patient have lesion on the, can you show the next slide please? So patient will have lesion on palms and soles, as the name suggests, hand, foot and mouth. On the buttocks, patient may be febrile, and on the palate. Okay. And this is very typical pictures. Next. And how do you make a diagnosis? Again, two siblings on the hand, foot, buttocks, and their oral cavity was also involved. Next. So how do you diagnose? It's mainly clinical, and you see clustering of cases in school and neighborhood. When we have HFMD, we'll usually see 3 to 5 patients in one OPD. So isolation, it's a self-resolving disease. No specific treatment is required. Acyclovir doesn't work. Just paracetamol and, fluids. Next. Warts always refer whether they are plain wart or anogenital wart, which are usually a sexually transmitted disease. Next. So you see these asymptomatic warty lesion over the dorsa of hands or feet or palms and soles. Filiform wart occur on hair-bearing area, scalp or face. Next. Finger-like projections, periangle warts when the wart occur around the nail, or genital warts when they occur on the genitalia in male and female. So it's a sexually transmitted disease, has to be treated separately as an STI. It's a notifiable disease. Next. So since no topical application will cure them, you have to send them to a dermatologist. Next. Mycobacterial infection. I just want to show that you should know, no text. Next, always refer whether it is tuberculosis or leprosy. Skin tuberculosis is pretty common. It's not that we don't come across, and there are multiple morphological forms. Next. So like this is lupus vulgaris, usually seen on the face or extremity or buttocks or exposed parts. It is slowly progressive. The history will be in 1 year or 2 year. Always painless. Persistent with atrophic scarring, you can see an advancing margin. So this lesion is resolving spontaneously, and there is history of TB in the family or neighborhood. Next. Again, lesion. Lesion is present for 2 years. There is atrophic scarring and advancing edge. Next. Again, so I have added few pictures just to make sure that you understand that if this kind of lesion is present, it can be skin tuberculosis. It is asymptomatic, very slowly progressive, and ask about the family history. Next. And this is scrophaloderma when bone is involved. So you see, it looks very, small lesion, but there is underlying destruction of the bone. Still asymptomatic, no symptom. Next. And this is again lichen scrophalosorum, asymptomatic papular lesion, which can also be a manifestation of cutaneous tuberculosis. Next. So the diagnosis is based on the histopathology, because in skin we cannot demonstrate AFB or CB-NAT, or lymph node, then we can do FNAC. Next. And it is treated like pulmonary tuberculosis only. In leprosy, there are 3 cardinal signs. There are hypopigmented or reddish skin lesion, loss of sensation, and in thickening of the peripheral nerve like ulnar nerve, radial nerve. And third cardinal sign is demonstration of M. leprae on the skin smear. Next. So when to suspect, these 2 lines are important. When you see hypopigmented or erythematous lesion, which can be single or multiple, hypoanesthetic to anesthetic in a patient from endemic region. So patient can be from Eastern Bihar, Eastern UP, Bihar, Chhattisgarh, Jharkhand. These are the area where the leprosy is endemic. So WHO says if there are 5 lesion or less than 5 lesion, it is paucibacillary. If there are more than 5 lesion, including now, it is multibacillary. Next. Next. So you can see a single lesion in a boy, but this is anesthetic, this is hypopigmented. But this is erythematous lesion. Involvement of earlobe is very characteristic in leprosy, and this is thickened nerve, right? This is greater auricular nerve. Next. But if the immunity is bad or immunity is low, then you can see multiple lesion. And there also sensation is lost or less as compared to normal skin. Next. And when I made slit smear from this patient, these are the AFB, which stain on Zeal-Nielsen staining. But you have to refer all these patients to a center because it's a notifiable disease. Next. Again, multiple lesion on face, anesthetic, and single lesion on a child, which is erythematous, but anesthesia is there. Next. So patient education is very important. कई बार वो कुष्ठ रोग है या कोढ़ का रोग है, they are very scared. So reassure that the disease is completely curable. This can be done in the dispensary or in your clinic. They do not need segregation. I always tell that I'm seeing these patients for 30 years and I touch them, I do not get the disease because leprosy is a disease of very low infectivity as contrast to tuberculosis. Counsel the patient to treat and finish treatment. Counsel the patient that they can stay at home. It is very important to screen the family contact because these days single dose rifampicin is given to all the family contacts. We ask the patient to inspect their hands and feet because they are anesthetic and for any ulcer, and residual sensory and motor deficit may remain. So we have to tell patient that they have to take treatment early and complete the treatment. Next. So this is the rifampicin. If it's possibacillary, less disease, localized disease for 6 months. If it is multibacillary or extensive disease for 12 months. But reactional episode can happen, which can be treated only by the dermatologist or skin specialist. Next. So next. Thank you very much. I think I have taken a lot of time.
Thank you, Dr. for such an extensive coverage. Participants are in a position now to identify. I think diagnosis is the most critical.
Yeah. I always say treatment is not
it.
important.
Once
Diagnose, it's very important.
Deal, keep seeing these patients repeatedly, but in general practice, many people get confused, whether it is, for example, even I was also, learning, many times we get confused between fungal infection and the bacterial infection that you showed. So that is the genesis of using these fixed dose combination showed you what
Sangeeta ma'am, actually there's some network error at your end.
or I mean,
I can take some questions if I just saw some question that somebody want to ask about scabies. So I made it very basic, just that people have to understand that steroid is not the answer for any infection, any infection. There is no role of steroid. So if we can say no to these fixed drug combination, I think my effort of putting this presentation 130 slides is worth it. If I can just pass on single message that you don't prescribe fixed drug combination containing steroid. Okay, so somebody has asked me that few words on leukoderma. Leukoderma is okay, I am reading few questions. Can I take them?
Yeah, sure. Please go ahead.
Okay, so somebody has asked me to say some words about leukoderma. Leuko is like white. White, and derma is dermis. So any white lesion on the skin is leukoderma, right? But in India, most people take leukoderma for vitiligo, and it's a very, it's a more of a physical, more of a mental disease. It's a patch on the brain rather than on the skin. I tell you, it is a absolutely benign condition. I'm seeing these questions and I'll take them one by one. So vitiligo, if there is a patient and if you're sure it is vitiligo, the white patch is because of vitiligo, please send to a specialist. Topical steroid has to be given, but these days we don't give steroid, we give tacrolimus, or which is, immunomodulator drug rather than a steroid. And okay, so but there can be white lesion because of post-inflammatory hypopigment. It is treatable. Leukoderma, if you are equating this term with vitiligo, it is very much treatable. There are medical treatment, there are phototherapy, there is oral treatment, and there are surgical treatment. Now, whatever it is, like, it is a treatable condition. And I tell you, it's more a patch on the brain, rather on the psyche of the patient and family, rather than on the skin. So I think if you send us, we are very good at counseling these patients, because the medical treatment, if it doesn't work, then you can give them surgical intervention, and it works really well, and it is available in practically every government hospital. Okay, then there was a question about sunscreen should be applied. See, we live in a tropical country. Sunscreen, if not applied properly, it's a costly molecule. It should be given, for me, we should take care of when we should expose to skin and when sun, and how we should expose to sun. So number one, if we apply patch versus time of treatment. So I'm talking about sunscreen. So sunscreen should be applied if you have a condition that worsens with sun exposure. Suppose patient has allergics, I'm having too many questions on skin conditions that are not infections actually. Yeah, that's a good. So,
because you did not cover those. The idea was not to, go to that. I think.
Yeah, because then it will be whole dermatology. But just a word about sunscreen. We have a beautiful brown skin. We do not burn. We do not develop skin malignancy. Okay, so even if you don't apply sunscreen, it's fine. It is not about dark. It is about, this is our, if we have Fitzpatrick 6 type skin, most of the Indian belong to 4, type 4. And if you do not have a condition that worsen on sun exposure, like polymorphic light eruption or systemic lupus erythematosus, then you don't need sunscreen. What you need to do is physical barrier. You can take a small folding umbrella, which should not be printed or white or pink, fancy. It should be black or navy blue in color. Preferably if it can have a silver lining on the inside, so that the black or the blue color absorb the rays which are harmful, sun rays, and the silver lining will reflect the rays. Okay, so never go for fancy printed umbrella, they are useless. Walk in the sun, walk in the sun shade, like walk in the shade, walk in the shade. Okay, wear big goggles which are UV protective. And I always say I do not like sunscreen because the application of sunscreen is not easy. Firstly, you have to apply sunscreen 20 to 30 minutes before you step out in the sun. The amount has to be around 1 teaspoon for the face. It is economically not viable. And secondly, it has to be repeated after 3 to 4 hours. I can't do it, so I don't apply it. Because after 3 to 4 hours, I'm sitting in the OPD or I'm in the middle of a seminar. It is impossible. What I do when I drive my car, I wear my gloves in summers when I'm wearing half sleeves, or I can cover my head, or I can wear goggles, or when I'm walking from parking or going out in the sun, I will take an umbrella. I always carry umbrella in my big purse, or in my car I always have. So that's a better idea. But if you are going, because if you're sitting, I'm sitting in my bedroom there is a light coming, that's a sunlight. So UVA will cross the glass. Okay, so that is unavoidable. Even if I'm sitting, these all LED bulbs, they have ultraviolet radiation. But if you're going out on the holidays to the mountains or the beach, there both the snow as well as water, they reflect sun rays. So our exposure to the light or ultraviolet radiation becomes very, very, very high. Then you get sunburns. So then you can, it's important to take sunscreen, and that has to be repeatedly applied in a generous amount, which is very difficult to apply. And the SPF should not, for Indian skin, the SPF should not be more than 25. People who apply SPF 50 or this, it's useless. As the SPF goes high, the acceptability of the sunscreen becomes very greasy. It becomes very difficult to apply on the skin. Or you can, if you are too conscious of your this thing, then apply like the cricketers do. They apply physical sunscreen, which is zinc oxide or titanium dioxide. But it always shows. SPF is sun protection factor, and it decides the efficacy of a sunscreen. But if you have a disease that gets worsened with sunlight, then you have to, apply sunscreen, higher SPF more. No, the sunscreen do not contain carcinogen. And psoriasis ka treatment is, I can't tell you in a one line.
I think we can leave these questions
Yeah.
for
So
right now.
cellulitis antibiotic is like
Yeah.
amoxiclav. You have to give. Most of the time, I will admit the patient of cellulitis because it can proceed. It can. There is no compartmentalization of deep dermis and subcutaneous tissue. So आज वो cellulitis है, कल वो necrotizing fasciitis में बदल सकता है. So I always prefer injectable. I'll give amoxiclav and amica. So to cover both gram positive and gram negative. If it is necrotizing fasciitis, I do add anaerobic cover also.
There is one question about patient scratched his head, has bad smell from the head and from his fingers. Also, after scratching the head, he also used ketoconazole weekly, but that did not help. What could be the problem here?
Maybe secondary infection, pus for CS. If bad smell is always for two condition, I told you. It's Pseudomonas. Gram negative. Can be anything. Or patient has a pre-existing disease of the skin that also needs to be addressed. So I think refer.
And then there are, I think, a few questions about benzyl benzoate cream.
Yeah,
Permethrin.
I will say I think you should stop getting indenting benzyl benzoate. 3 application is not. People are not, despite counseling. I have a counselor in my OPD, and his job is to just tell how to apply permethrin. So 90% of the people will not apply permethrin correctly. How can you expect a patient to apply benzyl benzoate all over the body 3 times at 12 hourly interval? And it has got many contact dermatitis or allergic dermatitis. So benzyl benzoate has neurotoxicity, so many things. I don't like the molecule. It smells bad. It stains the clothings. They're all poor people. You can't mess with their life. Like, they can't spoil one set of clothes. So benzyl benzoate should not be. Ivermectin is good for scabies. I rather prefer ivermectin, and ivermectin has become a very known drug with COVID. So give 12 milligram of ivermectin. My standard is give ivermectin to the whole family. It will take care of your GI infestation also.
There is one question about can anyone die because of this application? Shampoo for pediculosis and the patient died.
No, not at all.
There should
Ivermectin,
be some.
pehle benzyl benzoate, if people drink, और गामा बेंजीन हेक्साक्लोराइड लिंडेन जो आता था पहले, so that they had neurotoxicity, but permethrin doesn't have. And it doesn't come in lotion formulation, so cream कौन पिएगा?
It must be something else, you know,
might be something else.
some
No
other
relation.
illness or wrong route of administration, you know.
No. Even then, it's not possible to die of. Not at all. I can't buy this theory.
Okay. Why permethrin is not applied on the face? There was one question.
I'll tell you why. Because in adults, face is one area. In adults, in babies, we do ask them to apply. In adults, face is an area which is never infested with scabies mite, because it has got, in 1 centimeter, it has got 900 pilosebaceous unit. So mite has no place to enter, right? And we have in our body, we have only 10 to 12 mites, which are more often in the interdigital cleft, lower abdomen and genitalia. Rest everywhere the lesion are because of the hypersensitivity or allergy. Okay, so don't apply on face.
Okay, we didn't know that.
Yeah. In
Thank
children,
you.
because pilosebaceous unit are not developed, then they get lesion on even scalp, palms and soles also. Adults will never get lesion on palms and soles because of the very thick stratum corneum, which is very difficult to penetrate.
Then there is a question about infections with MDR and PDR organisms, especially nosocomial infections. What is the line of treatment? Will systemic antimicrobials help? If so, what to prescribe for what duration?
So you can you reach on whether they are methicillin resistant or methicillin sensitive or resistant organism only once you do culture and sensitivity. If you have that facility, then if it is MRSA, then you give clindamycin. Linezolid is the oral drug I prefer, and vancomycin is the IV drug that I prefer. And for nasal carriage, I told you mupirocin 1% twice a day for 15 days in the perianal and both nostrils.
Linezolid, because it is given orally, I'm quite worried, you know, as a public health, person working on it, quite worried about the misuse of this linezolid and resistance developing to this good drug.
Yeah,
you know,
that's why I always say that please send these patients for pus for CS if you have gram negative. Because you know my hospital will put the spectrum of antibiotics which are commonly used and available. I will not switch to linezolid just like that, presuming. I have to have an evidence.
3 drugs, cefixime, linezolid, ferropenem. These are wonderful antibiotics which can be given orally.
Reserved. They should be reserved, and only if there is, other indication, I will not prefer. I am very sparingly use antibiotic. For me, like antibiotics are not to be used just like that. And I tell you, if we concentrate on hygiene, most of our problem gets solved.
Even, one thing I would like to add, topical, she covered that topical antibiotics also have the potential to develop antimicrobial resistance.
That's what I said, ki never apply soframycin. Never apply their potential sensitizer also, neomycin. They should be stopped. Like hospital should not indent them.
वो बाजार से खरीद लेंगे हॉस्पिटल में नहीं.
That's why I'm saying now all these fungal infections are happening because everybody for fairness uses betnovedin.
We are obsessed as an Indians.
Yeah,
we are obsessed with the color of the skin. We are so fascinated by the white skin.
But they become monkey skin. I told them you are monkey. You're red. You become red skin monkeys, no?
Okay, one more thing, you have covered this, but I would like you to, re-emphasize on that. Many a times you have a single abscess, small little abscess, single abscess. Instead of incision and drainage, people resort to giving systemic antibiotics for that.
It should be given. When there is abscess, I tell you, all infections below dermis need to give systemic
Okay.
antibiotic. That's
Okay.
a rule.
Even if it is a single abscess less than 1 centimeter?
Yeah. Size doesn't matter.
Okay.
It
Okay.
can be, see, we have blood vessel everywhere.
Okay.
So,
Okay, that's the rationale.
yeah, that's the rationale.
But definitely, I have seen people, giving antibiotics, systemic oral antibiotics. Patient is giving a history of insect bite. There is
Yeah, see, every red thing, every inflamed thing is not bacterial infection. If you have insect bite, it also becomes red.
And with antibiotic, certainly incision and drainage would be needed.
Yeah. So I don't think that IND only if it is fluctuant. If it is not fluctuant, it will subside with oral antibiotics. We hardly do IND, not even once a week, in a OPD of 600 to 700 patients. And I think all my friends who are listening, if they're working in the surrounding area, and if they have understood anything, my OPD load should go down, because I'm seeing all patients like a primary care center and not as a tertiary care center.
When I spoke to her to come on for this webinar, one of her concern was, unnecessary, patients should not be referred to tertiary care.
Yeah.
There are very clear-cut indications. You can clinically diagnose many of these skin infections, especially the viral ones. You can treat them, scabies, you can treat them. Why should
Dr.
these
Sangeeta,
patients...
I took this 1 hour lecture, 1.5 hour. I actually, I have another, in the from the Europe, something like my lecture is from 7 to 8. I happily agreed, you are my friend. Secondly, it's a great job to tell that antibiotic misuse should not be there. So I am passionate about that. This should be stopped. Topical steroid containing fixed drug combination should stop. Otherwise, I could have asked my assistant professor to take this lecture. But I think their passion does not parallels mine. And somebody is writing, please share the PPT. It is this, you buy standard treatment guideline, it has much more information about vitiligo, about other diseases you are asking, with beautiful photos. Like all my life, I have a collection of more than 1 lakh pictures. All are in, best pictures are in STG guidelines.
Yeah, and you generously, gave it to us for use this. And quickly, just 5 more minutes, because I think मैंने ये cover करना था, but अभी time नहीं है. Sample collection,
Okay.
when they are taking for, just quickly cover that.
So sample collection is very, very important. You wash your hands, you may not wear gloves, that's fine, but do not touch the swab stick. Okay. And do not clean with antiseptics. I have seen that people will clean it with Savalon or with spirit and then take the, so you are dislodging all the bacteria. So from the area you are taking, you just touch it, smear for 1 gram stain and put rest in the the tube, and that is to be done.
किस एरिया से लेना है, मतलब आई थिंक
Purulent area, you have to take it, you can clean it with saline. If there is too much of crusting, then you remove the crust and take from underneath the crust. Crust removal is again, sometimes people come with a whole crusted, and I do not give systemic antibiotic. I just tell them that okay, you remove all your crust, apply topical antibiotic, and you will be thinking that I'm exaggerating. I'm not exaggerating. Nothing will work on a crusted lesion, not even systemic antibiotic.
Yeah,
Because that nidus of infection is there underneath the crust. So the crust should be removed. So even when you are taking a sample, like I showed you a lesion of ecthyma with adherent crust. If you take from above, it will not show you anything. It will show just the normal flora. But if you roll off normal saline to remove crust and to remove dirt and debris and contaminants.
Dr. Archana, pus sample है, there is an abscess, they want to send this for culture and sensitivity. तो वो मतलब
If there is an intact pus, you just aspirate it with 18 gauge needle or 20 gauge needle.
you know, I can share my personal experience. I had an abdominal abscess, big abscess. It was aspirated. It was sent for culture and sensitivity. It came as no growth.
Yeah, sometimes antibioma can also form. If you have taken a lot of
Even without no antibiotics, just the abscess was there. It was aspirated, and it
so maybe
how
it
is
was not abscess, it was a cyst.
No, it was a clear cut.
Yeah, appellation does cause recurrent folliculitis.
No, what precautions should be taken? I'm asking this question when you are sending this type of pus sample for culture. Is there any precaution
Yeah,
that needs to
suppose
be
if
taken?
it is an intact abscess, okay, it's a fluctuant abscess. I will rather say either you just clean it properly, clean it, and then either you with the you aspirate or make a small incision and take a sample. Somebody, Archana Kumari says, please post test.
Because they'll get a certificate only
Oh,
when they do
okay.
the post test.
Okay.
Anyway, but it was a wonderful presentation, Dr. Archana. मैंने आपको बोला था कि I don't know any other dermatologist. I know only Dr. Archana, and I know she will do a very good job because she's involved with teaching and with standard treatment guidelines. She's been there right from the beginning, and she knows what is the approach, what is the concept behind. So that is why I request. Thank you very much for
Thank you
sparing
having me here.
British Journal of Pharmacology.
No,
Sorry,
no, I
dermatology
am
is taking a
editor.
lot of your time.
No, I'm editor of Indian Journal of Dermatology, Venereology and Leprosy. That's our national journal with an impact factor of 3.1. Proudly
Okay,
can
that's
say.
very
And I'm associate editor for British Journal of Dermatology.
That's a very prestigious
Yeah,
journal
that's
and a very
that's a very
prestigious.
prestigious. Yeah, somebody said zinc oxide is very safe. It's a very good for to restore the barrier function of skin. Zinc oxide.
Okay. Thank you so much. It was extremely useful. I sat through completely and learned a lot of new things.
Thank you, sir, for your kind words. My job is accomplished if somebody can take some carry home messages.
Absolutely.
2-3 carry home messages. Apply soap and water even if there is infection. Please do remove all crust. Do not prescribe antibiotic based on your acumen. Clinical acumen never matches culture sensitivity. And number 4, never ever give potent steroid combination. Thank you.
No, certain things which you have told when we are reviewing the national list of the essential medicine will certainly keep in mind. And maybe
Yeah.
if needed, we may bother you also.
Yeah,
So
sure,
have
sir.
a very good.
Anytime for patient care.
Thank you. Thanks so much.
Thank you so much. Thank you. May I leave now?
Yeah, thank you so
Thank
much.
you. Thank you so much.
Yeah. Siddhi,
Somebody is asking cost of book.
1,000, around 1,100 or something. Okay, Siddhi, I think there is hardly any time. Can I quickly do this thing? If you allow, I can do this. How do you optimize? Maybe I'll skip some of these.
Yes, ma'am.
How much time will you take?
10 minutes, I'll try
Yeah,
to.
then go ahead.
Because I think this was an important topic. Can you see my screen?
Yes, ma'am.
Okay.
Mm.
Can you see? I think. Just a minute. First slide, can you see?
Yes, ma'am.
Okay, we need to be worrying about antibiotics because the golden age of antimicrobials is going to be over. We have, up till now, we have had several antibiotics which we could use because even if the resistance developed. But in this, century, that we see that the new antibiotics coming into the market have declined. This is a failing market. No new antibiotics are expected in a next few years. So we need to be dealing with these infections all these times. And I always say germs are smarter than humans. They have remained one step ahead of us. If we have developed a new antibiotic, they have developed a mechanism to defend themselves. So resistance is nothing, a survival tactic of the germs to remain in this earth. And I think on this universe, these germs have been there before us, and this is spreading because of the misuse, overuse of antibiotics. And whenever we needed antibiotics for chicken pox, there is no need for systemic antibiotics. Just because we are not able to differentiate, we give antibiotics. We have over believed in the power of antibiotics. They will not work on viruses, they will not work on the fungus, they will act only on the bacteria. And whenever, even within bacterial infections, we've seen where a narrow spectrum antibiotic can work, we have used broad spectrum antibiotics. And I always give the example: we have a needle, we have a small knife, we have a sword. Broad spectrum antibiotics are like swords, but we have been using them like anything. At the slightest indication for infection, at the slightest indication for use of these systemic antibiotics, we are using broad spectrum. And even when we make a good choice of antibiotics, it's been seen that we don't use it for appropriate duration. For example, fungal infection, she told you that it has to be applied for 2 to 4 weeks because it stays in the skin layer, and the skin layer for renewing needs that much time. So if you stop it early, it will come back again. Similarly for some bacteria. And of course, patients also are to be blamed because they are consuming, and we need to be worrying about this because the highest number of cases are coming from two regions, Asian region and African regions. And this will out, because we know how the COVID has spread to other, all other countries within no time. So similarly, these resistant bacteria also travel all across the globe. So we need to be, stopping this. And on top of it, you must be getting news alerts of outbreaks, some unusual, pathogen or virus is being detected, because, I always say nature is always in control. If you try to suppress them, nature will, they remain in nature, but they will come at the opportune time here. So with antibiotics, we need to look at that we don't overprescribe, we take a good choice, don't choose an overly broad spectrum, give it by appropriate route, dose, duration, and irrational combinations. She gave you some examples. Another very good example, which is very commonly used, is mclox, amoxicillin with cloxacillin. These are not pharmacologically compatible combination. Amoxicillin is given 8 hourly, cloxacillin is given 6 hourly. How can you combine them two? And also the advantage of combining amoxicillin with cloxacillin is not there, rationale is not there. Today there is not much time. I could have gone into, we have been using these irrational combinations for ages, and then omission or delayed doses are equally to be blamed for resistance developed. Because if the, with antibiotics, you have to respect the time interval between the dose. 8 hourly, you must have seen antibiotics are prescribed 6 hourly, 8 hourly, 12 hourly, 24 hourly. They are not, 8 hourly is not same as TDS. 12 hourly is not same as BD. So please remember that there has to be an appropriate dose interval. So you cannot take care of this problem. You cannot combat the problem of AMR unless you follow all three. Infection prevention and control, she told you about how do you do this. Antibiotics, anyway, we know how we are using it. Diagnostic stewardship is equally important, that you make a diagnosis. In the absence of the diagnosis, if you use these antibiotics, that just shows that there is no certainty. You have not made a diagnosis, or there is no knowledge about this, So making a diagnosis sometimes may be difficult, but you can always write the differential diagnosis. You can also write the when you write down signs and symptoms, differential diagnosis, perhaps things become more clear, and then you can target your treatment accordingly. So timely definitive diagnosis is very important, and if required, you need to do culture and sensitivity. You must get that sample done. Causative pathogens should be identified, because then only you can target your make your antibiotic cover, particularly when you started with a broad spectrum in a life-threatening situation. You need to narrow it down to a narrower spectrum antibiotics. This can happen only if you have identified the pathogen, and if you have done this culture sensitivity before starting the first dose of antibiotics, that is the best time to do it. Even one single dose of antibiotic can render your culture and sensitive no growth, sterile. And if you have not stored the sample, collected the sample properly, and even if you send it to the lab, you may not get a good yield because the sample was not collected properly. So that's diagnostic stewardship is very important. Identify whether it is non-purulent, purulent, and if possible, if there are no constitutional signs, fever, lymphadenopathy is not there, systemic features are not there, perhaps localized treatment will do. So like these are the purulent infections. IND is also, debridement. IND is important part of it. Blood cultures may be required for some of these infections, as she said. Cellulitis and the necrotizing fasciitis, very soon it can spread and cause damage. So but there are ways in which blood culture should be. There are several factors which will help in getting a good yield from the blood culture. So today I don't have that time, but for this skin swabs, usually these are not preferred. You don't use the cotton swabs. You have to use the Dacron or Rayon swabs for this. That will have a good yield, and flogged swabs are better. Swab the viable wound tissue. बीच में से dead tissue से लेंगे तो उससे कुछ grow नहीं होने वाला है. And viable tissue, not dead or dying necrotic or pus. बीच का सेंटर से लेंगे तो परहैप्स वहां से नहीं ग्रो करेगा. Then if you are taking a tissue biopsy, take it from the advancing margin. Needle aspiration may be preferred if there is a bullae, vesicle, closed wound, undrained abscess, sinus tracts. This will help. So I think I can quickly pass this. Stewardship activity here would be that you follow the guidelines. There have been national guidelines by ICMR, by NCDC. They are revising it now, but we have been also publishing this for last 20 years. 6th edition is already in the market. 7th edition is under print. We have a very big chapter on skin and soft tissue infections with all these pictures there, and and needless to say, Dr. Archana was the lead contributor here. So you would find all these details, what she presented today in that. Then we need to save some of these antibiotics, because some of these antibiotics are also used in animals, and we know there is a rampant use of antibiotics in animals. So now recently, just few days back, WHO has come out with medically important antibiotics that we need to preserve. Earlier they were called critically important antibiotics. So these are the ones, fourth generation cephalosporin, fifth generation cephalosporin, fluoroquinolones. These are beta lactamase producing inhibitors. These are the ones that we need to be protecting. Another way of optimizing the antibiotic use is to use this aware classification. The excess group of antibiotics, here the antibiotics have been divided into 3 groups: excess, watch, and reserve. Reserve, as the name suggests, these linezolid, tigecycline, azithromycin, all these are reserved ones. But look at the excess one also: amoxicillin, amoxiclav, doxycycline, sulfur group of drugs, nitrofurantoin. These are all excess groups. Whenever needed, prefer to prescribe antibiotics from this class. Watch group should be also less sparing, used. Azithromycin is one of the drug, which is very rampantly used, but this is in the watch group because this has a high resistance development potential. So we need to protect this very important antibiotic from developing resistance. So anyway, we all know when to prescribe, but equally important is when not to prescribe. When you can do with the topical ones, when you can work with a needle, why do you need to take out a knife or a sword here? So when not to prescribe, if it is a very localized small lesion, no constitutional symptoms, try to treat it locally. And because antibiotics are not the only management, you have to do the debridement, you have to do the IND if possible, required for this patient. Alone this may not be happy. Then topical, be careful about the topical antibiotics as well, because you in market you get triple antibiotic ointment, all 3 antibiotics mixed in one, because they also have AMR development potential, so we need to preserve them. Empirical therapy, be careful, follow your antibiotic policy of the hospital, because this will vary depending on the site of infection, the most probable organism, the sensitivity pattern, whether culture and sensitivity was available, not available. So it has to be escalated, but de-escalation is equally important. These other factors, in wound infections, again, this is one area where antibiotics are very commonly used. How do we handle these wounds? Whether the diabetes patient, sugar is controlled, skin preparation. I still see even in corporate hospital with JCI accredited hospital, they're using shaving. Do not shave. This causes abrasions on the skin and cause infections later. So you have to look at other ways of handling the infection, because they are also equally important. Antibiotics, if don't work on them, you may lose your patients. Many a times drain is there in the body. Many people think that as long as this drain is in place, they need to give antibiotic. Again, drain tube in the patient's body does not mean that you need to give antibiotics for this patient. One single dose of perisurgical antibiotic is enough to take care of. Rest all we need to depend on the sterilization, the asepsis technique that we use when we are handling, making incisions or handling with wound. De-escalation is a very, very important approach to rescue or reduce pressure on antibiotics from broad spectrum to narrow. if you had started with 2, narrow it down to 1, from IV to oral. These are the ways of reducing the use of antibiotics. Oral, many people think severe means that you have to use IV. That does severe infection or serious patient does not mean that you have to use always IV preparation. You can use oral equivalents that are available. For that reason, I say Cefixime is a very important IV to oral switch drug that we have these days. But I see Cefixime being used in outdoor department for everything. Cephalexin is not there, amoxiclav is not there, but Cefixime is being used. Normal delivery patients, as a package, they are given Cefixime. Please preserve this very important antibiotic, which is very useful. And then stop decisions are equally important. We may you if you have to use antibiotic, you think it is indicated, please go ahead and use it, but stop decisions are equally important. Many times, especially patients who are admitted in the hospital, they keep getting antibiotic because nobody reviewed it. It was started and then the physician or the clinician forgot. After 10-14 days, the nurse reminds them, sir, इसका कितने दिन और देना है? अच्छा, कितने दिन हो गए? 14 दिन हो गए? ओह बाप रे, इसको तो 5 दिन से ज्यादा नहीं चाहिए था. This is the kind of reaction that we get many a times. So stop decisions are equally important, and document all these things. Documentation, we are very bad at documentation. For whatever reason, we may give 100 reasons. Patient load hai, heavy work load hai, time nahi hai. I think it is more of a question of attitude. Recently, an advisory was issued by DGHS, and he urged people, appealed to people to write an indication. Why are you giving an antibiotic? At least that will make us think about it. Is an antibiotic really needed for this patient? So this is the algorithm, that you can see, this starting of antibiotic, then continuation of antibiotic. These are all very, considered decisions should be based on sound reasons, logic, justification behind it. It cannot be a gut feeling. हाँ, मुझे लग रहा है ये infection होगा. By this time, after 48 to 72 hours, you have the reports available with you, you have the response of the patient coming in, so you are in a better position to decide. So review is very important. Just don't see, एक दिन start कर दिया तो उसके बाद 5-7 दिन, 10 दिन, 14 दिन तक antibiotic चलता रहेगा. So review is very important, and if you need it for a longer duration, oral parenteral antibiotic therapy in outdoor also can be given. Many a times these patients with orthopedic pyogenic arthritis, septic arthritis patients, they need it for 4 weeks, 5 weeks duration. So after 2 weeks of hospitalization administration, patient can be asked to come to the outdoor for getting the daily injections and like that. So there are different strategies available for this, but always I would say today there is not much time to do this, but document these decisions. Because कितनी बार पहले से लिया, कब कितनी बार recurrent हुआ, we don't know. So many of these decisions, so you have to always balance this act. And I know it's a very difficult task, but with considered decisions, you can because antibiotics are a different class of group of medicines, because where the effect of this medicine on individual patient in addition has a impact on societies, because then the MDR, PDR will spread. So these are not like paracetamol. These are not like diabetes medicines or hypertension, which will affect on the individuals only. So you have to protect the future generations. What is it that we are leaving for our next generation? We have had a golden era of antibiotics. What is it that we are leaving for the next generation? It's a very important question to ponder over. And I think if you ponder on this question, a lot of antibiotic use will decline. I think with quick this thing I could only do this much. Siddhi, you can post the post test link here. Dr. Urbi Das, you had raised a hand. We do, specific courses on this antimicrobial stewardship. If you don't, we circulate that information also. If you are interested to know the details, how to do it, I know there are a lot of clinical situations where you don't know how to go about it. Those things can be answered during these. So I think we will be doing one course in March or April. If you are interested, you can join in that antibiotic stewardship course. And the recording of the session is available on the YouTube. Siddhi has put that link in the chat box. YouTube link is there. But I think she takes 4 or 5 days to, make this video. So after maybe by next week, you should see this YouTube. If you have missed anything, or you can share this YouTube link with your friends. I think a lot of people wanted to join, but they could not join. They had some problem with the joining on the WebEx. But nothing to worry about it. YouTube link is there. They can watch this YouTube. Post-test link is there. Please fill it up. And feedback link bhi dal do, Siddhi.
मैम डाल दिए फीडबैक और यूट्यूब की लिंक भी.
Okay. Thank you.
Thank you, ma'am. Thank you all. We have our next session on 16th March on musculoskeletal disorders. Please do attend the session. And also the posters link is in the chat box. You can continue with the link. Kindly submit your feedbacks, and the YouTube link is also there. You can access all the previous SPGs and also this lecture after a week. And the certificates, you will be receiving the certificates within 7 days. Thank you.
But there is a requirement that you have to do both pre and post test.
Yes.
Many people otherwise keep writing कि मेरे को नहीं मिला है. The major reason behind that is if we don't get a matching post test this thing, we will not be able to issue the certificate. The idea is not to worry about the numbers. We don't have any cutoff here, but idea is that because we are all online and it has its own limitation, but to keep us engaging, we have kept this modality for active engagement. And I think you would enjoy the tests also, because these are reflecting the day-to-day scenarios. And we have marked the correct answers, and in the feedback we have given the explanation about it also. So even if you would like to read it later, it would be available to you. So I think if any feedback on these would be welcome. The post test link दोबारा से डाल दो. Some people are asking for it. Maybe they
Yes, ma'am.
missed it earlier.
Yes. Yeah.